अभी तक हम लोगों ने डिफरेंट टॉपिक के बारे में हमारा चैनल पे डिफरेंट वीडियो बना रहे थे। आज सेरेब्रल विजुअल इम्पेयरमेंट जो है उसके बारे में पूरा ओवरव्यू हम लोग देखेंगे। कौन सा रीजन की वजह से सेरेब्रल विजुअल इम्पेयरमेंट होता है, कैसे उसको आइडेंटिफाई कर सकते हैं, उसके साथ साथ उसका बेसिक मैनेजमेंट हम लोग बताएंगे। ठीक है, माई सेल्फ सौभिक चक्रवर्ती। आज हम लोग पढ़ेंगे कि ब्रेन बेस्ड ब्लाइंडनेस। ब्रेन बेस्ड ब्लाइंडनेस मतलब इस सब से हमें पता चल रहा है कि जो भी ब्लाइंडनेस हो रहा है उसका मेजर रीजन है ब्रेन। ओके, व्हाट इज सेरेब्रल विजुअल इम्पेयरमेंट? Cerebral or cortical visual impairment, it is the disorder characterized by the visual deficit resulting from the damage to the visual pathway in the brain rather than the eye. So we know whenever we are seeing image is forming at retina, then it is getting transmitted to the brain. So there is no problem in the eye, but in this pathway from eye to brain there is a problem that are posterior to the lateral geniculate body. So we know that like there is a visual pathway, and in that visual pathway there is a portion, that portion is known as a lateral geniculate body. So post chiasma there will be a problem, and that is known as a including that visual processing area. What are the visual processing area? Visual processing area means occipital, excluding occipital lobe, parietal lobe, temporal lobe, frontal lobe. These are the visual processing area, and all this portion will have problem. Next is, according to that Saki et al., a verifiable visual dysfunction which cannot be attributed to the disorder or anterior visual pathway or any potential co-occurring ocular impairment. It means whenever we are seeing there is a cataract, according to the grade of cataract we can judge that patient might have this much visual acuity. But in this case, most of the time what will happen in this case, after seeing your eye or after seeing your function, these two will not correlate. Let's suppose there is a cataract, that cataract will cause more severe visual impairment what it supposed to cause. So there will be no correlation between the ocular pathology as well as the clinical manifestation. National Institute of Health CVI working group defined as CVI is a spectrum of visual impairment caused by an underlying brain abnormalities. So it is telling cerebral visual impairment is happening due to the underlying abnormalities that affects the development of the visual processing pathway, which is affecting again the same thing. It is telling that visual pathway, processing pathway will be affected, and there will be deficit in the visual function and functional vision. So there is two terminology according to the National Institute of Health is telling. One is visual function and second is functional vision. What are the visual function? Visual function we can see here that visual acuity, visual field, contrast sensitivity, dark adaptation, color vision. These are the assessment of visual function. But in another case, what are the assessment of the functional vision? Vision to learn, orientation and mobility. Where is the target? How it is oriented? How to move towards the target? All these things is the part of functional vision. Daily living skills, communication, sustain near activities. Whenever the child is reading, child is not only seeing the target, it is the child is trying to grab what are the information presented in front of them. Then visual access to the information. So now child is reading, so child is gaining information from the text. So these are the assessment of the functional vision. Measured separately for both eye, for each eye, like right eye and left eye we used to measure for the visual function. But in case of assessment of functional vision, always we will measure with the both eyes open. Next is scale based test will be there. Scale based test means there will be single variation under control. It means like if you want to consider a patient with visual impairment, what you will do? You will check their visual acuity. That will be enough to tell that patient may have visual impairment. But in this case, functional vision, there will be multiple parameters will be there. Like in our CVI series, we are going to discuss that there will be multiple parameters like orientation, mobility, then where is the object is presented, what is the object, and recognition of the object, recognition of the facial expression, recognition of the orientation of the object, then identifying routes, identifying object in the crowded environment. All these things we are going to assess. Then only we can tell that child may have a functional vision deficit. And always we have to remember that visual parameters are involved in case of visual function, but in case of functional vision, not only visual parameter, whenever you are sitting and reading a textbook, okay, so that time what is happening? You are sitting, so let's suppose your posture is not maintained, you are keep on moving, rocking movement here and there, then how you will concentrate on that target, near target? So that is the thing where we have to look. Okay, so in case of functional vision, we have to look beyond only our eyes. Next, why we should know about cerebral visual impairment? The reason is, you can see the reason clearly, that in national registry that collected data over 2,155 children, and among them 24%, that is the most prevalent diagnosis, 24% was having what? Cerebral visual impairment, and followed by retinopathy of prematurity, that is 16%. So you can see that retinopathy of prematurity is not the major cause of blindness in children. Now cerebral visual impairment is the major cause of the cerebral childhood blindness below 3 years of age. In countries with national healthcare system that more widely track causes of visual impairment, such as United Kingdom, CVI accounts for up to 48% of the cases of severe childhood visual impairment. So let's suppose you are getting 2 patients with severe visual impairment. Among 2, one of them will have cerebral visual impairment. Can you see? 50%, around 50% child will have the cerebral visual impairment. That will be the causes of their visual impairment. Second, a study done in India that is telling that 24% of children were diagnosed to have characteristics suggest of the cerebral visual impairment. Among them, 81% of these children were diagnosed to have low risk CVI, and 19% were having high risk CVI. You can see in multiple regions the cerebral visual impairment is the major cause. Another study done by the Dr. Niranjan K. Pehare, it is also in that study also it is telling that cerebral visual impairment, that is a 33% of the cases, that is also a major cause. You can see here CVI is a major cause of profound visual impairment in our area, and majority of them manifested delay in several areas of the development. So whenever you are getting a child with developmental delay, that time always you have to suspect that can be associated with the cerebral visual impairment. Next, we can see that here in case of that South India, you see 33% of the children were having cerebral visual impairment, and ocular visual impairment with cerebral visual impairment associated for the 11% of the cases. And then according to the American Academy of Pediatrics, you can see American Academy of Pediatrics is telling that cerebral or cortical visual impairment is a leading cause of pediatric visual impairment in nations with developed economies like USA, UK, and is increasing in those with developing economies like us, India. So now I think you got a major reason that why we should know or how we should talk about the cerebral visual impairment. Now, how we will identify the child is having cerebral visual impairment? One, that child can have a color preference. Whenever you are showing a red color toy, child is looking and holding the toy. But whenever you are showing different color, let's suppose green, child is not looking at the target, or child is not paying attention to the target. Next is movement preference. What is movement preference? Whenever any target is moving, any spinning target, child is going to grab it and child is taking the target and child is looking at that target. Next is visual latency. What is visual latency? Whenever you are moving a target from here to there, we are supposed to look from here to there like constantly, but what the child with cerebral visual impairment do? Say they will look at the target very slowly. Now, like this, they will take time to react that with the object. Next is visual field preference. Visual field preference, one side of the visual field they will prefer more compared to another side. Visual simplicity. Visual simplicity means if the target is too much complex, child will try to avoid it. Variable blink reflex. Variable blink reflex means that whenever any threat object is coming in front of your eyes, you will close your eyes suddenly. But in case of cerebral visual impairment, there will be variability because they are not able to process the threat. Visual nobility means whenever the familiar target is there, child will see. if any new toy is coming into his area, then child will try to avoid that target to see. Absence of visual guided reach means whenever target is there, we will look and we will take the target, but usually with cerebral visual impairment they will look another side and they will take the target, because there will be a problem with the sensory integration. First they will look at the target, where is the target, then they will look away from the target, then take it. Understood? So looking at the target and taking this need a multisensory stimulation, but the children with cerebral visual impairment have deficit in multisensory integration. Next will be visual complexity. Visual complexity means if the target is too much crowded, child will try to avoid the target. Next is light gazing. What is light gazing? We can see here that child is try to fix the light. The child is try to stimulate him by this light. So this is called as a light gazing, where the child will look at the light for a prolonged time. Next, we can see in this graph that in case of sighted control and ocular blind, there is no changes in their ocular overall cerebral part. But here in this case, you can see cerebral visual impairment. There is a density is less among all the neurons. That is the thing where we are representing the cerebral visual impairment. Now we are understood that how we can identify children with cerebral visual impairment. Now we are going to discuss that how to grade it, how we will know if this child is having more CVI or severe CVI rather than another, or rather than mild or moderate CVI. This is the phase 1. Phase 1 is severe CVI, moderate CVI, and last is mild or high functioning CVI. Okay, so if let's suppose light gazing is present all of the time, then we will give it as a 0. Then let's suppose a movement preference is present half of the time, then we will make it as plus 0.50. Then let's suppose child is not like absence of guided reach all of the time, then we will put it as a 0. Then after calculating all of the 10 characteristics, we will sum it. Then let's suppose it is coming around 3. Then if the score is between 0 to 3, then the child will have severe CVI. But in another case, let's suppose where let's suppose some of the time the child is doing movement preference 0.5, some of the time child is seeing light gazing, some of the child there is no child is looking at an object and child is holding that object, so there is no absence of guided reach. Next, let's suppose visual field preference is not there, child is looking overall the visual field. Then child is handling any kind of visual complexity. Then child is making eye contact, and child is identifying different variable new objects, so visual mobility is also not there. Okay, so then after calculating, let's suppose other characteristics also, we can see the score is 1, 2, 3, 4, 5. So this child can have a phase 2 cerebral visual impairment. Got it? So this is how we basically segregate the severity of the cerebral visual impairment. Okay. Next, we can see that in ocular visual impairment, the search pattern is very much normal, where we can see that as the child is not able to see, then the child due to the ocular visual impairment, child is not able to fix the target. But in case of cerebral visual impairment, you can see there is a multiple area of search. So we can see to see a target in a crowded environment, child have to put more effort if the child is having cerebral visual impairment. Here, if the target is getting changed, and now you can see the segregation is almost more. Previously it was like this. In this area child was focusing, now you can see the area is getting more. Okay, so always we have to remember that if the target is too much crowded, it is difficult for the children with cerebral visual impairment to process that information. Here in case of control, we can see that their parietal lobe and their temporal lobe, means ventral and dorsal stream, is perfectly fine. In case of ocular visual impairment also it is also fine, but in case of cerebral visual impairment you can see that there is very much damage presented in their dorsal and ventral stream as well. Here we are going to discuss that the difference between ocular visual impairment and cerebral visual impairment. What are the main differences there? First definition is that impaired vision due to the damage or disease to the eye in ocular visual impairment, but in cerebral visual impairment this is the impaired vision due to the brain damage, brain injury affecting visual pathway or processing center. Where is the site of the damage? In site of the damage is eyes for ocular visual impairment, but in case of cerebral visual impairment site of the damage is the brain. Next is what are the common causes? Common causes of ocular visual impairment is cataract, glaucoma, refractive error, retinal disease. But in case of cerebral visual impairment, hypoxia, hypoglycemia, epilepsy, these are the major reason. Okay. Next, eye appearance. After seeing the eye, you can say that patient might have ocular visual impairment, but in case of cerebral visual impairment, it is not consistent. Visual behavior consistent with the eye condition. According to the severity of the disease, we can see the child may have this much visual acuity, but in case of cerebral visual impairment, we cannot tell directly by seeing the eye. Light response, child can have photophobia. In case of cerebral visual impairment, child may have a light preference or light gazing. Visual acuity loss depend on the ocular condition, but visual acuity may poor despite normal eye examination. Although there is a normal eye examination, after that also the child can have a less visual acuity if you are checking through the different test. Suppose diagnosis. How you will diagnose the ocular visual impairment? By seeing the posterior segment, anterior segment of the eyes, by doing the fundoscopy or doing the OCT, but by doing the cycloplegic refraction or diffraction. But in most cases, cerebral visual impairment will diagnose by seeing their birth history, brain imaging, and other diagnostic tools like seizures monitoring by EEG. These are the thing, or VEP. We can diagnose the child may have cerebral visual impairment. Second is associated condition. Child can have a ROP. Child can have a ROP in case of ocular visual impairment, but in case of cerebral visual impairment, child may have epilepsy, cerebral palsy. Management will be for ocular visual impairment will be glasses, surgery, low vision bed. But in case of cerebral visual impairment, the management will be vision therapy, environmental modification, multidisciplinary support like physiotherapy, occupational therapy, special education, speech therapy. These are the sensory integration therapies needed to manage cerebral visual impairment. Okay, now we are going to discuss that what are the main causes for cerebral visual impairment. One is HIE, where there will be a presence of delay in birth cry. Next, there can be brain lesion. Any kind of portion of the brain can have a lesion, and that lesion will have a defect on that particular portion of the brain. Next, the patient can have a encephalitis or meningitis. These are the thing. If the baby is getting injured, or if any kind of person is getting injured by the injury, that brain injury can cause a cerebral visual impairment. Neonatal hypoglycemia, where there will be a less sugar present in their body due to the less feeding. So that feeding, the problem can cause a cerebral visual impairment. We can see in this classic case that in HIE or hypoxic ischemic encephalopathy, there is a periventricular changes is there. But in case of hypoglycemia, we can see that there is a changes in the occipital lobe. Okay, so these are the classic sign by which from the MRI we can see that cerebral visual impairment is present. Brain malformation, these are the basically congenital cause, where there will be hollow presence cerebelly, means half of the brain will be absent. Then next we can see the scission cephaly. This here the portion will be on of the side will be absent. Next, this is the lesion cephaly. Lesion cephaly means the sulcus and gyrus. Sulcus and gyrus means what? The fold of the brain is known as a sulcus and gyrus. So this fold of the brain will be absent in case of lesion cephaly. Next, hydrocephalus. Hydrocephalus means the brain will be filled with the cerebrospinal fluid. So their white matter will be get damages. So this is the abnormal EEG response, and this is normal EEG response. We can see that if the patient is having multiple episodes of epilepsy, so they will have problem, and they can have a cerebral visual impairment. Okay, so now we're going to discuss that how do our brain see. So whenever we are seeing a target, then what is happening? This target is seen from our retina. Target is going to reach the retina, and retina is trying to process that information to the brain. And how it is processing the information to the brain? Via the optic nerve. Since this optic nerve is going to attach this information to the occipital lobe. Now this occipital lobe is sending the information to the parietal lobe for the identifying where is the target, and this occipital lobe is trying to send the information towards the temporal lobe to identify what is the target, So after identifying where is the target, what is the target, now the brain is going to give the response according to the target. So this response is done from the frontal lobe. We are going to discuss it in next slide also in a different manner, that whenever the visual information is coming, this visual information is going to reach the eye, and this eye is sending the information via the visual pathway and going to reach the visual cortex, and now the visual cortex is sending the information to the occipital lobe, to the parietal lobe or to the temporal lobe, and then this is sending the information to the frontal lobe to give a perception. Understood? Now picture form on the retina and it converts into the electrical signals and transmit the information to the occipital lobe, and then it transfer information to all over the brain for the visual processing. This is the reason that whenever we are seeing the object, we are not seeing from the occipital lobe only, we are seeing from all over the brain. That is the reason. Previously we used to call CVI as a cortical visual impairment. Now we are telling it as a cerebral visual impairment. Next we can see that how occipital lobe is seeing. Occipital lobe main function is color vision, contrast, clarity as well as visual field. Next we can see that parietal lobe is doing the 3D mapping, where we are presented, where is the target presented, that is done from the parietal lobe. Temporal lobe is having multiple area. Basically middle temporal lobe is adding the movement to any kind of visual perception. Next, temporal lobe basically work as engaging our memory, and identify any kind of objects presented in front of us. So identifying letters, number, and symbols is done from the left temporal lobe, and right temporal lobe is recognizing the face, root and other expression. So experience, we can see that it is a multi-layered process is happening, and according to this process, what we are doing, we are giving the our response. We are giving the response like Thanos. The control center of our any conscious movement is our frontal lobe. Now by seeing this picture, you can see if anyone is giving you hand to shake, how we will identify where is the target, where is the hand. You will identify from the parietal lobe. Now you are going to shake the hand. But you have to identify that what is the object that person is showing. If that person is giving you the bottle, so you will hold the bottle, you are not going to shake the bottle. So now if you are identifying that the person is going to give you the hand, so then you will shake the hand. So this identification is done from the temporal lobe. Where is the hand? That is done from the parietal lobe. Now you are giving the response accordingly. It is done from the simple frontal lobe. So this is how it is happening. But where is the hand? I've already told that 3D mapping of the object is done from the parietal lobe. Now color, contrast, clarity as well as the visual field is seen from the occipital lobe. Now identifying this picture, you can see that here the Albert Einstein present. It is identifying from your right temporal lobe, and you can see that 6 minus 3 is equal to 3. So this calculation is done from the left temporal lobe. By seeing this picture itself, you can see that how our brain process our vision and how all of the brain is involved for our visual processing. Now we are going to discuss that how we see the visual field. Basically you can see that, let's suppose here I am showing that back of my brain, downside, right side downside, you can see there is a portion. This portion is known as a right down occipital lobe. Now which portion I will see? I will see that left side up portion. Are you getting my point? That whenever I am touching my right down portion, I am seeing left up. As soon as I am putting it up, right upside, then it is coming left down. So it is opposite nature. Whenever we are seeing the visual field, it will be an opposite nature. Okay, so as I discussed that there will be two pathway, one will be dorsal stream and second will be ventral stream. Dorsal stream basically means we are transmitting the information from occipital lobe to the parietal lobe, and in ventral stream what we are doing, we are transferring the information to the occipital lobe to the temporal lobe. So this dorsal stream is basically useful for identifying where is the target, spatial orientation, spatial processing, location, movement, spatial transformation, spatial relation according to the object. But in case of temporal lobe, whenever that what pathway we are saying, in what pathway what is happening, color of the object, texture, picture details, shape, size, process, and identifying a previous picture and matching the picture, these are the things done from the hot pathway. Now we are going to discuss a very brief about the trees of vision. In trees of vision what is happening, that whenever we are showing object from right to left, then what is happening, the left eye is transmitting to the object to the opposite side and right side is going to transmit the information to the other side. Then this retina is sending the information to the optic nerve, then optic chiasma, then optic tract. In optic tract, one pathway is going to reach the midbrain where there will be reflex vision. If suddenly anything is coming in front of you, what will happen? You will close the eye to avoid the threat. Okay, so this thread pathway is basically known as a superior colliculus pathway. Okay, so this is going from the optic tract. Now it is coming to the lateral geniculate body, then optic radiation. In optic radiation, after reaching the optic radiation, it is going to reach the occipital cortex. Occipital cortex is sending the information to the dorsal stream and another way is sending the information to the ventral stream. So this ventral stream again having the right side and the left side. Right side is basically sending the information to the identifying that innate ability to route finding in a crowded scene, recognizing facial expression, recognizing people. But in left side what is we are identifying? Letters, number, recognizing words, shape of the objects and recognizing animals. Are you getting my point? That in ventral stream how it is identifying, in ventral stream is going to which lobe? Ventral stream is going to the temporal lobe. In opposite way we can see that dorsal stream is going to the posterior parietal lobe, and it is again is helping us to visual guidance of the movement, arms and hands, legs and feet and the body, as well as finding cloth in a pile, objects in a clutter and object on a pattern background crowded of the text. So this is how we are identifying. This is the what pathway in the temporal lobe, and this is the where pathway in the occipital, in the parietal lobe. So this is how we process our whole vision. By seeing this tree of vision, you can understand that all over the brain is engaged for our visual processing. So as I started our presentation as telling us brain-based impairment of vision, it is a very much bigger umbrella term. Below that we can see the cerebral visual impairment is there, as well as the perceptual visual disorder. What is the meaning of perceptual visual disorder? It means you are able to see the target but you are not able to process the target. That is also a thing you can see. This is the 100% contrast where we can see that the girl is absolutely visible to us, but as well as we are decreasing the contrast, we can see it is very difficult to identify the girl face. Now we are decreasing the visual acuity. Now also we can see we can identify. But now if we decrease the visual acuity further 1/60, now we will not able to identify the face. So I am trying to convey that whenever the visual acuity is less, then it will be difficult for the child to process or identify the face, or identifying their mother face or identifying their father face presented in front of them. Now if we change the contrast of the face, that also matters for the child. So if we give a highlighter for their mother face or give a dark lipstick, then that will enhance their contrast and that will make the child help the child to identify their face. We can see in that picture. Now this is the CV questionnaires. In CV questionnaires there is a basically 6 block is available. In 6 block we can see we are basically identifying different things. First block is visual attitude, second is ventral stream dysfunction, third is complex problem, third was dorsal stream, and fourth is complex problem, fifth is other senses, and last is associated characteristics. In first block we can see we are trying to check their fixation, how well they are fixing, absent of eye contact, cannot focus or nor objects, tilts head when looking object, often stares the light or windows. We are trying to identify the problem. The child is having what kind of problem. In visual field, we can identify the child is paying attention only to the object in the center of the field. So we are trying to identify child is preferring any kind of gaze or not. In visual attention, we are trying to get for how much time or for how many moments the child can maintain their attention. As well as in ventral stream, we are trying to understand that what are the objects child can identify properly, like does not recognize everyday objects such as apple, bike, house, ball. In dorsal stream, we are checking the child is having problem in day-to-day basis in their where pathway, like does not see levels of difference whenever they are getting up to the stairs, so they are not able to identify the stairs gap properly. So that can be due to the dorsal stream problem. In case of complex problem, we can see that the patient child is having problem with the cutting, building stocks, tying shoelaces. So whenever we are seeing the child is tying the shoelaces, we have to understand that there is a multiple processes going on. How their fine motor coordination is going, then they have to identify the gap between that object, then none again they have to maintain their attention, then they can put it in a different hole. Okay, so these are the things we have to ask to the parent to check the child is having problem, child is having issue with the cerebral visual impairment. Let's suppose if one of the six box, child, mother or father is telling that 4 of the box is having only one issue, that time also have to suspect the child can have cerebral visual impairment. You getting my point? Let's suppose child mother is telling there is an absence of eye contact. This is the one box. The child's mother is telling that recognition object is not properly there. Dorsal stream, let's say child is telling has not interest in the complex picture. Then 4th, the child is telling, let's suppose here 6th, child is telling is generally anxious. So among this all the question, if at least 4 of the question among 6 box, child, mother, father is telling, it is the positive sign that child may have a cerebral visual impairment. For CVI to be considered, likely at least one question in 4 of the 6 boxes needed to be answered, needed to be addressed. The next is, it is very difficult for us to ask all of the question. So according to the Gordon Dutton, he told you can ask only 5 questions and suspect the child can have a cerebral visual impairment. What was the first question? First question was, does the child look away from you when you approach them? It is trying to get the attention. It is trying to judge the visual attention or the facial recognition. Which lobe we are trying to identify? We are trying to identify the temporal lobe dysfunction. Temporal lobe or ventral stream dysfunction we are trying to understand. Next is, does the child have difficulty seeing things in crowded place? So this crowded place is known as a, where is the target present? This one is known as a simultagnosia, problem with the while whenever we are seeing a crowded thing. So that thing is known as a dorsal stream dysfunction. Third question is, does the child have trouble reaching for things accurately? Again we are seeing the optic ataxia. In optic ataxia, what is the thing? Child will tell here is the target, but child will not able to take the target properly. So they will grab the target here, or they can grab the target over there also. Okay, there will be overshooting and the undershooting of the target will be present. That is the optic ataxia. Does the child have difficulty seeing things on one side? We are trying to identify there is a visual field preference present or not. So this is the thing, another thing we are trying to get. And the last is, does the child have problem with identifying, recognizing familiar people or object? Again we are trying to identify the ventral stream problem. If you notice this 5 question, you can understand that whatever the question we are asking, that is we are trying to get the information from the 10 characteristics what I have discussed earlier. Next, common condition associated with cerebral visual impairment will be the difficulty when seeing. We can see that whenever we are changing the contrast, or we are changing the visual acuity, we have problem to identify an object. Okay, whenever the blurring of vision, we have problem to identify or process the information. Simultaneously means that if the multiple things are going on, then there will be a problem to process that full information. Here we can see the children, whenever if the child can only able to focus on one letter, suppose it is written over the board and child is only able to focus in this one, then how they will maintain the focus for overall this sentence and able to copy it from the board. Are you getting my point? Why the children with cerebral visual impairment have difficulty in writing or copying from the board? This is the main reason. Maybe they are not able to pay the attention properly. Maybe they are not able to process the full information at a time properly. Then how we will manage? We'll discuss it later. That optic ataxia I have discussed. There will be problem in the perception. Perception can be good, but there can be problem in the action. So the child is able to process the line is horizontal only, but they will not able to put that through the mailbox. We can check it from the with the help of the LIA mailbox. The grasping is very much different for the optic ataxia patient. This optic ataxia means basically inaccurate visual guidance of the reaching. Next, we can see if the target is slow moving also, the children with cerebral visual impairment can have problem. So this condition, when the target is moving, they will not able to process the thing. That condition is known as a acantopsia. Prosopagnosia basically means that if the child is having problem in the right temporal lobe, they will not able to see the face properly, because that facial recognition area is basically affected. So then they will see the face like this. Next, we can see that whenever we are starting the therapy, so we have to understand these three things: staying within the limit, second is using alternative, and last is extending our limit. So first we have to grab their attention. For children we can motivate to extend limit, but for adults we can use alternatives. So we have to understand that for the children there will be a presence of neuroplasticity that will be very much good, because the child is in a developmental phase. So always we have to extend the limit, but first whenever we are starting the therapy we have to put in our limit, then we can motivate the child for doing other things. So whatever the things we are going to do in therapy purpose, what is going to happen? The physical ability, visual abilities, cognitive abilities is going to see the changes in school, home, community. Okay, so skills like our therapy can have a greater impact on their overall quality of the life. Next, we can see that in our study, we did our study for outcome of visual vision therapy among children with cerebral visual impairment. Then we got to know that multisensory stimulation, we can see that is a high impact on improving the visual acuity. Like we have shown different types of object in front of the child, then make the child about the taste of food, then engage tactile by touching the spoon, smell the food, then we are instructing the child to have the food, then at last child was having the food by seeing that object. Okay, I will demonstrate it that how we have. Next is whenever there is a children with cerebral visual impairment not seeing or fixing the light properly, then we have to start the therapy in a dark room. Then we can if the child started looking at the dark room, then we can make the semi-dark room, and at last our goal is to make the child see in a fully illuminated room. Use of the glasses is very much needed, because to provide the clarity of vision, as well as most of the children with cerebral visual impairment have accommodative disorder. So in accommodative disorder, it will be helpful. For children with cerebral visual impairment, we can give multiple tactile books, or the multisensory books will be very much useful for them. Next, we can see for adults, if let's suppose the adult is having this left hemianopia, then what will the patient will have the problem to start the reading. Then giving them the alternatives, like you can move the book in horizontal to vertical manner, so then the patient will start reading properly. Next is, I'm just giving a brief description about the hypoxic ischemic encephalopathy changes, and the patient came to us at 9 months of age, poor eye contact, reported by mother. Then we have did the visual acuity check, then we got visual acuity is 20/2000, is very less for the age. Child was showing that +4 hyperopia, and child was presented to us in the down gaze presence, down gaze. And in functional vision, we can check the poor eye contact, inability to fixate and follow object properly, and not reaching nearby object. We did the intervention for 2 months with the glasses to support the accommodation and visual stimulation exercise, tracking fixation exercise, and object reaching coordination tasks, parent guided home program. Then we can see that there is a huge change in the visual acuity. We can notice that previously it was 20/2000. 20/2000, then after 2 months of therapy, we can see that there is an improvement up to 20/84, and child start establishing eye contact, eye contact with the caregivers and improve visual attention and the interaction, and child started reaching or grasping object properly. You can see that out of the demonstration, I'm just trying to give the demonstration of the vision therapy. Out of the vision therapy I have provided to the child, like you can see that after switch of the light of the whole room, I am trying to make the child focus only on one object, then child is trying to grab the object properly from that thing. You can see that it is a very colorful objects are there to grab child's attention, and child slowly started getting the attention, and child is giving the interest for that therapy. Next, we can see in this video that I am showing this child with the mirror with the red light, because the red light is trying to get the attention and increasing their facial contrast, and child is getting the interest, and child is giving the response to the mirror. Here we can see child is doing eye hand coordination exercise, where child is trying to grab the object properly, and we can see the child is getting the information and trying to see from her brain. Now we can see in this video that this child is trying to grab this magical wand, and this is basically very much interesting because it is showing different color as well as the movement, and trying to get their visual attention. You can see here I am using the Cyanide Vision integrator. The Cyanide Vision integrator is basically very much useful with the auditory clue, and other multiple colors are available to give the visual attention or visual curiosity for the children with cerebral visual impairment. And you can see it can improve the contrast sensitivity as well as their fixation, and reaching of the object also can be facilitated from this therapy. Now we can see that whenever we started the therapy for these children, what I presented in the case, you can see that reaching was very much inappropriate, but after the therapy we will see there is a huge changes in her reaching. See, this is the post therapy changes. So these are my reference. I think you all got a brief knowledge about the cerebral visual impairment.